So if we go to the next slide here, I just wanted to give a sense of, from a parent's view, we've talked to many of you about what you were looking to get out of sessions like this. And today we have a threefold objective. First, we just want to come back and ground everyone in really the underpinnings of what is a low-grade brain tumor, and then importantly, what are the implications for treatment, and try to do that in very much a straightforward way, because we realize it gets confusing quickly. We really want to spend some time, and we're really blessed to have Dr. Kieran with us, to talk about what's happening, both current trials that your child may be eligible for and proposed ones that are underway. And then lastly, put that in the context of understanding the choices that parents must make in deciding which treatment path to follow, and really talk about the pros, cons, because again, this is something where we want all the parents to feel like we're in this together and that there's resources for you to take action. So with that as the objectives, just a couple minutes on the foundation and how we came to be. We were founded back in 2007, and you'll often hear our foundation called the Pediatric Low-Grade Astrocytoma Foundation. That was really meant to get specific focus on low-grade brain tumors, because I'll talk in a minute about how it was really an area that was not receiving any research funding, and we felt it was important to be very specific about what we were going to fund in research. But then we realized that a Kids Brain Tumor Cure Foundation was a name that people could better understand and would really make it more accessible to families as a way to talk about our foundation. So you'll hear myself and Dr. Kieran talk about the foundation in both ways. And as a result of the work of people on this call and many others, we're proud to say that we've raised over $12 million specifically for low-grade brain tumor research, and that's really as a result of a lot of great effort for many families. And our mission is pretty straightforward. We very much want to just accelerate what we call the bench to bedside, to really take treatments that were really just ideas and give the funding that allows the researchers to get them to clinical trial to help our children. And then also to make sure that the medical community knows that we're here and that we're a force from the standpoint of setting a scientific agenda that's really going to drive meaningful progress for our children. And then very importantly, to support our children and the families around making sure you have the resources to make good decisions. Just a second on what we call the research doom loop. We fund an effort at Camp Sunshine for low-grade brain tumor families and get to speak to a lot of families. And in talking to one father, Daniel Itzkovitz, he was struck by the fact that it's really hard for parents to understand how fundraising works. And he had a breakthrough in terms of understanding how he and his family could make a difference. And I felt it was important to share this with you. And we talk about breaking the research doom loop. And a low-grade brain tumor fits all the characteristics of an orphan disease, in that there's 1,000 families every year just in the U.S. who have them. But again, some of the larger cancers, that's really not enough to create much momentum. So the funding that the foundation does and the many parents involved are involved with really is our hope for these therapies that Dr. Kieran's going to talk about. And the doom loop goes like this. If you look to the upper right, there's limited research dollars. There was really no funding just a matter of years ago that was dedicated to low-grade brain tumors. Because of that, there's no research activity. Even if there was really compelling science to drive forward, there really was no market for it, and researchers were just not attracted, because the bottom line is they need to have funding in order to do the great work. And then the drug companies, if you look to the left, generally avoid pediatric drug development because it's really high risk and low profit from the standpoint of the numbers and the risk involved with that, which results in something that exists today, and Dr. Kieran will talk about, which is when you talk about first-line treatments for many low-grade brain tumors, it's really carboplatin vincristine and TPCV, which are treatments that are shockingly 25+ years old and are not targeted. So the difference now, we think, is that we've started to actually get the funding that allows clinical trials to happen, and we're starting to break the doom loop. And I thought that was important just to set the stage as we go into what's occurred around advancements, and it is a result of some of the funding that the parents that are on this call have initiated. So with that, let me introduce the star of the show, Dr. Mark Kieran. Dr. Kieran is the clinical director at Dana-Farber of the Brain Tumor Center, and he's also the co-director of the Pediatric Low-Grade Astrocytoma program at Dana-Farber Cancer Institute. Mark, welcome.
Well, thank you very much. So what I'm going to do today is transition from the talk that we had last May, where we talked really about the treatment and outcome for kids with low-grade gliomas, although I'll highlight that a little bit, to one where we really talk about where things are going, which obviously means having to bring you back to some of your high school biology class. And I'll try to simplify things as much as possible. Again, it's not critical to understand all of the details as long as you understand the concept. And it's not important that you had been on the last call, because, again, we're going to go in a slightly different area, so you won't miss anything if you missed the last call. So just before we begin, it's important to know that I don't have any stocks or patent rights or employments with any company, but I obviously have a large number of agreements for the testing of experimental drugs in kids with brain tumors. And in fact, we're going to talk a lot about some of those drugs today, since that's really part of the goal of today's talk. And therefore, that kind of association is at least important for you to be aware of. So as you heard, what we're really going to do is first begin this concept of the way your child's low-grade glioma was originally diagnosed, which is based on the microscope, to where we're now moving, which is a better understanding of the underlying biology that actually makes it tick. And once we've done that, you'll see why we now often refer to low-grade gliomas as RAF disease, and I'll explain what that means in a moment. And then once we understand what the underlying trigger of your individual child's tumor is, we can then presumably design much more specific treatments that hopefully will be both more effective and less toxic. So to kind of give you a general overlay of pediatric low-grade gliomas compared to all of the other brain tumors, you can see that they make up about 30% of all of the tumors we see in children. We're not going to talk about any of those other types. We're going to focus on this one group. But even just this one group is somewhat more complicated than perhaps we would like, in part because much of the nomenclature comes from some of the historical analyses that were done before some of the newer technology was available. And so as you'll see, there are basically three ways we can talk about these tumors. Sometimes we refer to them by what's called their World Health Organization grading. So this is the microscopic appearance grading system that was developed initially some 50 years ago that we continue to use today, that divides things into grade 1 or grade 2 tumors. And you can see some of those here: pilocytic astrocytomas, low-grade gliomas, fibrillary astrocytomas, and pilomyxoid. Sometimes we actually refer to the tumors by their location, not by their grade. In this case, optic pathway, hypothalamic, posterior fossa, tectal. Sometimes we actually refer to them more by their predominant cell of appearance within the tumor, a ganglioglioma, an oligodendroglioma, PXA, a DNT. The specifics of those are not important. They're just slightly unique characteristics of the appearance of the cells. Now, obviously, one of the complexities here is that many of these can be overlapping. So you, for example, can have an optic pathway glioma that's a ganglioglioma. You can have a pilocytic astrocytoma that is also a tectal glioma, and it accounts for a lot of the confusion in the way we talk about things. In fact, obviously, neuropathologists for the last 50 years have spent a lot of time creating little boxes in which they define something as being a DNT because it meets certain characteristics under the microscope, at which point it gets into the DNT box, versus something that has a slight nuance difference that would instead make it called a grade 1 or a grade 2, a ganglio, and so forth. And these boxes are what neuropathologists spend a ton of time trying to put your child's tumor into, on the assumption that that tells us something. And unfortunately, when a neuropathologist says this child has a malignant glioma, that clearly tells us how it's going to behave. When they say it's a low-grade glioma, and all of the things you see in front of you are low-grade gliomas, actually the behavior between them is not all that different, and understanding some of those nuances becomes important. And I think, in fact, one of the things we're beginning to discover is there aren't actually divisions between these things. It's more like a gradation, and tumors, depending on a little bit more of which area grows and which one doesn't, means that someone who starts with a grade 2 tumor can have progression of only a grade 1 tumor. Someone who starts with a ganglioma might have progression of a low-grade glioma, telling you that, in fact, the boundaries here are somewhat masked. And, in fact, it really gets us to the whole issue of low-grade gliomas, which is obviously, currently we use the microscope, discovered in 1674. So the microscope, even with all of its advancements, is basically 500-year-old technology. And if your parents are anything like my parents, you were told not to judge a book by its cover, and yet we look at the outside of a cell, and based on that outward appearance, we are meant to decide exactly how that will respond and to what therapy. And obviously, that's not a very easy or accurate thing to do. And so we're beginning to move away from that, and that's what we're going to talk about. And to some extent, this slide, in fact, reinforces that concept. So this was a paper that we recently published in which we looked at about 4,000 pediatric low-grade gliomas compared to about 6,000 adult low-grade gliomas. Under the microscope, they appear identical. There's no difference. These are what are called Kaplan-Meier curves, and obviously the top lines are, the dotted lines are for pediatrics, and the solid lines are for adults. And these are survival curves. And what you can see here is that whereas the majority of adult low-grade gliomas that appear exactly the same as their pediatric counterparts eventually transform into highly malignant tumors and result in death, for pediatric tumors, that almost never happens, and almost all of the poor prognosis is because of one particular subtype that's quite rare that we're not going to talk about. So from this point of view, it tells us that the microscope doesn't really tell you what's going on, because the same tumor, if you're a child, does well. If you're an adult, it doesn't. Of course, one of the concerns is maybe because it doesn't do badly until you're an adult. This is another analysis that we recently published in which this takes all of the kids, there were 1,100 of them, that had a low-grade glioma when the kids were 2 or 4 or 6 or 8, just like your kids are. And we said, okay, after these kids become adults, then do the tumors start transforming into the more malignant ones, and they're going to cause problems later in life. And in fact, as you can see from this almost straight line going across over what is 3 and 4 decades of follow-up, the answer is no. These kids, their tumors, when they become adults, still don't behave like adult tumors. Low-grade survivors of low-grade gliomas are survivors. And in fact, if you ask, what is the most common cause of death of a child with a low-grade glioma, it's not the low-grade glioma. The most common cause of death is actually a radiation-induced highly malignant tumor, because radiation isn't just an effective way to treat a tumor, it's also a very effective way to cause a tumor, and that's in fact what we see, which means you're more likely to die of your treatment than you are of your tumor. And you can envision how important that's going to be as we develop the decision-making about what therapies to use, when, and how.
So Mark, just to stop you there for a second, so you've said a lot there, but it does really set the stage, and as a parent, you get hit by so many different terminologies, location, type of tumor. But the low-grade category you're saying includes multiple tumors. They don't transform, right, into a malignant tumor, which is a high-grade category. And because of that, survival is very good for this group of children. Yep. Is that correct?
Exactly correct. So
okay.
Your almost, there's no guarantee in medicine, obviously, but the vast, vast majority of all low-grade gliomas will be long-term survivors. And it therefore means understanding why that is so that we can adapt the treatments. If the number one cause of your death is a treatment-related toxicity, clearly we shouldn't be using those kinds of treatments. So this next slide kind of begins to deal with the biology, and this slide will probably be a little bit confusing. And what I wanted to do was take you through it a little bit, because I'm going to show you this same slide about 10 times during this presentation, because it basically explains why different low-grade gliomas behave the way they do. So you can see the green arrow at the very top that refers to this growth factor. And normally what happens in normal cells, remember that a cell dividing, proliferating, which is obviously bad when it's a tumor, is in fact a critical normal step of development. We all started out as a fertilized egg, so we all started out as one cell, and we needed that one cell to divide billions of times in order to make us adults, which means cell division and proliferation are actually normal things that all cells have to know how to be able to do in order to make a final human being. And obviously what's going to happen here is tumor cells are going to reactivate something that should have stopped to allow the tumor cell to begin to divide at a time when it shouldn't. But cell division in and of itself is a normal process, and it is mostly regulated by this pathway you see in front of you, in which a growth factor binds a molecule or activates a molecule called RAS, which activates all of these things as it goes down this kind of waterfall to lead to activation and cell proliferation. And if the cell is getting this signal, this waterfall that starts with a growth factor, goes to RAS, to RAF, to MEK, to the TS molecule, to the mTOR molecule, to the S6 molecule, that's the signal to tell the cell to divide. And we're going to see how that gets messed up in some low-grade gliomas. The first of one is this thing called the TS complex, and a genetic disease that you can see off to the right-hand side called tubular sclerosis, and a subependymal giant cell astrocytoma, which is what that word SEGA means. So this is a genetic disease in which if you have the genetic disease, you usually get these tumors. They're low-grade gliomas, and we understand what causes them by virtue of this unique genetic syndrome. Now, I suspect virtually no one on the call has this genetic disease, because if you had it, again, we would understand exactly why your tumor is growing. But for those in the audience whose child does have this abnormality, we understand why they get these tumors. And so the question was, could we stop these tumors? And remember, this is something that we've now known for about 20 years. This mutation was understood long before any of the new biology that was originally funded through a Kids Brain Tumor Cure Foundation. So obviously, given where the mutation is, we look for a drug that could inhibit the molecule just downstream, so that as soon as that mutation tries to send the signal into the nucleus to divide, that we can cut it off then and there. And so what we try to do is inhibit the signal at this molecule called mTOR. And here's an example of a patient that you can see that has these tumors. In fact, this patient has multiple of these low-grade astrocytomas. We treated the patient with one of these mTOR inhibitors, and the tumor shrank. They took a drug holiday, the tumors grew back. We treated them again, it shrank, because these are effective at stopping the signal that the tumor is trying to send. And to some extent, this is exactly what we want. There's no chemotherapy here, there's no radiation. A single targeted drug hitting the pathway that the tumor was sending the signal to divide can be interrupted and stop that process. So in fact, in conjunction with an international trial that we've been working here with one of my colleagues, Mustafa Sahin, we're basically doing what's called a phase 4 study. And without going into the details, a phase 4 study basically means we know the drug works. In fact, if you go to any local pharmacy, you can buy this drug for this disease, for these tumors, because we already know it works. And now we're just getting more data on exactly how well it works. But at least here is the concept of a specific mutation for which we have a targeted drug that can stop those tumors from growing. The second genetic disease that's quite commonly observed is this other one called Neurofibromatosis Type 1, and their low-grade gliomas. And you can actually see the disease is characterized by a number of findings on the body that a good physical exam will identify. And so what you see in front of you is this thing called a café au lait spot. Café au lait, which means French for coffee and milk, is because they have the appearance of that kind of mocha color. In addition to, these patients often have these low-grade gliomas. They can occur most often around the eyes, but not always. They can occur actually anywhere in the brain, although this is most common. And in fact, if your child has a whole bunch of these café au lait spots and an optic glioma, that in and of itself guarantees that your child has this genetic disease. And the reason that's important is we know exactly what the mutation of NF1 is. It's an abnormality in that molecule called RAS, which is up at the very top of this signaling cascade. So although no signal is coming from the growth factor, the RAS is accidentally activated by virtue of this genetic mutation. And what that's going to do is start sending that signal down that pathway that we already talked about, to cause the cells to start to divide at a time when they shouldn't be dividing. Now, NF1 is an important disease for us because it, in fact, is one of the most common genetic diseases in all of North America. About 1 in 3,000 Americans has this disease, although other than the fact that they might have noticed that they've got these funny spots on their skin, many Americans don't even know that they've got it. About 15% of these patients get a low-grade glioma, but what's interesting is only about 1/3 of those ever cause a problem. In the other 2/3, they get these low-grade gliomas, they start to grow, they stop spontaneously, and they never affect vision or anything else, and these patients die of old age, many of them not even knowing they've got these tumors. And you would say, well, why is that relevant to my child? Well, if we could understand why it is that in spite of the fact that every one of these patients has the same mutation, only 15% get the tumor, means there's something else in addition to activating the pathway that must trigger this, and we're going to have to discover what that is because we don't know it yet. And then if you said, well, even of the ones that get these tumors, why do 2/3 spontaneously stop growing and cure themselves, whereas the other third need to be treated to do so, again reinforces the issue that there must be other things going on that we have yet not discovered that explain that. Because if we could understand what that is, we could then take those same on and off signals and apply them to your child's tumor and maybe make the tumor spontaneously stop without actually needing any drug therapy at all. Well, right now, if you said, if your tumor does need to be treated, how do we treat it? And obviously, based on what I just showed you for the patient with the genetic disease of tubular sclerosis, we have that mTOR inhibitor called Everolimus, or RAD001, and we said, okay, can you use it for kids with neurofibromatosis as well? And obviously, I'm telling you that because that's exactly the clinical trial we did. This trial was done through the Dana-Farber, but in conjunction with the Department of Defense, and that has to do with the fact that the Department of Defense is responsible for all NF1 studies in the United States. Remember that 1 in 3,000 Americans has this disease, so if you have an army of a couple of million people, then you've got thousands of soldiers that actually have neurofibromatosis, the majority of which don't even know about it, and hence their particular interest in this condition. So we just completed this clinical trial, and I'll tell you that we don't have any actual, we know some of the results. It hasn't been published yet. The results tell us that for reasons we don't completely understand, in spite of the fact that everyone has the same mutation, everyone has the same tumor, and everyone got the same therapy, some of the tumors dramatically shrunk and responded fantastically, and others didn't respond at all, which means that although we have made significant progress for some of these tumors, clearly there are some things we still need to learn to improve the quality of that treatment.
So Mark, let me stop you here again. So in layman's terms, this is so complicated when you look at this growth factor and the pathway down, but you've been good about explaining it to me that in a way you think of it like you just said, a waterfall, and cells normally operate properly, but when they don't, that's where you get the mutation and a growth of, say, a brain tumor. And you've talked about how you can turn them on and off. So when you look at what we have on the screen here, and you talk about it being a RAF pathway and low-grade brain tumors being RAS-RAF, can you just talk a little bit about, when you talk about the targeted nature, are you trying to turn off some part of that pathway which allows the tumor to stop growing?
Yep. So, you know, we for example, we've talked about the abnormalities here in the tubular sclerosis and in RAS, and the issue is that, again, in two different places, a mutation has occurred either here or down here that basically sends the signal. So from this mutation, it sends it from here down around and tells the cell to divide, whereas for NF1 patients, it starts up here, travels down here, and tells the cell to divide. And what we're basically trying to do is put a roadblock in, cut the wire that is sending that abnormal signal so that the cell that is dividing stops getting the signal to divide. In some ways, it's not the cell's fault that it's dividing, it's getting the signal to divide because the mutation has inadvertently turned back on a signal that should have disappeared after birth when your brain is fully developed, and for whatever reason, a mutation, in these cases a genetic mutation, have caused that signal to go back on. And now what we're going to talk about is, well, what causes that signal in people that don't have the genetic mutation? Why do their tumors start to grow? And that really has to do with an abnormality that we have now discovered right here in this molecule called RAF. And hence you can see that with all of the tumors from NF1 patients that have a mutation here, and almost all of the rest that have it here, is why we often refer to this as a RAS-RAF disease. And so the question is, what happens? What is the mutation in the RAF, or what we often refer to as BRAF gene, that suddenly starts to send the signal again that makes the cells want to divide?
And so these are names of genes.
So these are the names of genes. These are basically the pathways that send the signal, a little bit like if you think of a relay race at the Olympics where you pass the baton, a growth factor passes it to RAS, which passes it to RAF, which keeps sending it down the signal until finally it crosses, until F6 crosses the finish line and says, okay, you now have permission to start dividing, divide. And then the cell divides because it's being told to do that. Now you've got two cells that, because they both have the mutation in them, start the process all over again. And before you know, you've got 4 cells, 8 cells, 16, and eventually a mass.
Okay, great, thank you.
So the question is, what is this RAF molecule? Because for most of you on the call, you're probably saying, well, hold it, my kid doesn't have NF1. My doctor looked at their skin to make sure that it wasn't there, and they don't have tubular sclerosis. So what is it? Well, so just to take a brief kind of backwards, this is what the BRAF molecule looks like that accounts for most of the mutations. And it's made up simplistically of 2 pieces, what's called the inhibitory domain and what's called the kinase activation domain. And we're going to talk about these in a little more detail in a minute. Now, back in 2007, when the foundation had first supporting some of the research we were doing, we were looking at the genetics of these tumors. And what you see in front of you are the 23 human chromosomes. So the very top left hand is chromosome 1, across from it 2, 3, 4, 5, 6, 7. You can see it goes all the way down to the entire complement of human chromosomes. And what you'll notice, or what we noted back in 2007, was this small blip where there seemed to be too much DNA in this specific location of chromosome 7 that happens to be at the location 7q34. And it just so happens that 7q34 is the location of the BRAF gene that I just showed you. And so what happens here, the reason we see that blip, is that there has been a mutation where up top you see what is the normal BRAF, and what's happened is the activation part is still present, but the inhibitory section is lost, and it's replaced with another gene called KIAA1549, so that you've now got a new molecule in the genes, in the chromosomes of your tumor cells that have knocked out the inhibitory domain. And you'll often hear people refer to these low-grade gliomas as KIAA1549 truncated fusion BRAF, because that's the creation of this new molecule that, because it's missing the inhibitory domain and only has the activation domain, surprise, surprise, ends up activating nonstop. It starts sending the pathway, the signal down that pathway. The cells are told to divide, they divide, and each new cell has the same mutation, keeps dividing and dividing. And this, in fact, accounts for about 80 to 85% of all kids with sporadic, with non-NF1, non-tubular sclerosis mediated low-grade glioma, i.e. most of you on the call today. Now, one of the first things we did is, if we were going to be able to understand this, we had to be able to identify them in patients. And what you see in front of you is a genetic test that is used around the world now for the identification of these specific mutations. And it's again because you get this abnormal duplication of the activation domain. So on the left-hand panel, you can see that you have a red and a blue, because that refers to the 2 ends of the normal BRAF, whereas in patients with low-grade gliomas, which are the samples to the middle and right, you can see that there is one of the green, but there are now two of the red because one of the activation loops has been duplicated, and so you've now got twice as much activation as you do inhibition, and that's what causes these to divide. We've developed another test for centers that can't do that slightly more complicated test. This is called the nested PCR reaction, and we now run this test around the world, China, the Middle East, Asia, as well as in some places here in North America that can't do the original test I just showed you. So there's now no good reason not to be able to get, from a molecular standpoint, exactly what mutation your child has got. And that's going to be critically important, as I'll show you in a minute, because that's going to determine the therapy.
So Mark, this is John Ragnoni again, the parent voice, and I'm watching the questions come in, and I'm going to try to thread those throughout as we have the hour together. So is this a case that anyone can take advantage of these tests, Mark? And can you just talk a little bit about, questions are coming in around if you have tissue, if there's been an operable surgery where tissue is available versus an inoperable. Can you address that, and also how does that play into the tests you're describing?
So to do these tests, you just need a tiny piece of tissue. Obviously, if the tissue doesn't contain any tumor cells in it, they got more the normal area of the brain around the tumor, you can't make the diagnosis. But if anyone's got tissue, any major center will have these tests. And if not, there are programs, including the one here, funded actually through a Kids Brain Tumor Cure Foundation, that allows us to do this testing for you. So this can be done if it needs to be done, either locally, or if not, you just need to let us know.
Okay, great. And one more question that came in, Mark, related to the BRAF mutation. There was a question asked about the relationship between BRAF mutation for low-grade gliomas for kids' brain tumors and the BRAF mutation in some melanomas. Can you draw that connection and how parents can think about that? Yep.
So actually, I'm going to talk specifically about the BRAF mutation, often referred to as the V600E mutation, in a couple of slides, because it turns out that's a separate therapy. What we've been talking about so far, that's on your slide right now, is what we refer to as the truncated fusion BRAF, duplicated BRAF, or again, some people call it the complicated name of KIAA1549 BRAF. They all mean the same thing. They're this duplication. So we'll deal with the mutation in a moment. So the question again is, I already told you that we have discovered the mutations in the two genetic diseases, and we've talked about the major abnormality, this truncated fusion in patients that don't have a genetic mutation. And the question now is, how would you treat those patients? And the one thing I'll point out is, as was just mentioned, we did discover that there is a small percentage of low-grade gliomas that have not the truncated fusion BRAF mutation, but instead have this other one, and I'll talk about it later, so I won't talk about it now. And then we found another couple of percent that have actually the mutation up at the growth factor level in these molecules called FGFR1, EGFR, PDGFR, or TREC-B. And again, that just means that it's even one step higher, but those signal through RAS, which then signal through RAF, which start that whole chain. So it almost doesn't matter where along the chain it is. If you take all of these ones together, everything except tubular sclerosis, you can see that all of the mutations are at BRAF or above, and they account for about 95% of all kids with low-grade gliomas. So the question is, here we've got these RAF or above mutations. What do we do with them? And obviously, since I already told you both for NF1 and for tubular sclerosis, we use an mTOR inhibitor. The obvious question was, could you also use an mTOR inhibitor in these kids? And so, before I get to that, I just wanted to mention, because it's for full disclosure, one of the things we did, also funded by Kids Brain Tumor Cure Foundation, was we discovered that actually about 5% of kids with low-grade gliomas, in fact, do not have any abnormality in the RAS-RAF pathway. They have it in a completely different pathway called MIB-L1. And to some extent, what that means is everything I'm saying is kind of 95% accurate. Obviously, if we're trying to treat people along this RAS-RAF pathway, but they're one of the 5% that have a MIB-L1 mutation, since it's not on that pathway, those drugs can't work. And understanding those nuances is going to be important. But if we talk about the 95% that are in this pathway, can we use the mTOR inhibitor again? And the answer is, here's another clinical trial that we have already completed where we took kids with sporadic, non-genetic forms of low-grade gliomas, and we treated them with this drug. And I wanted to just tell you a little bit about it so you get a sense of exactly what it looks like. So here's a circumstance where this is a drug that's already approved for many cancers, including those SAGAs that we talked about initially. It comes in both a pill and a liquid form, which is obviously important for little kids, many of whom can't swallow pills. It only requires once a day, so you only have to give it once. And the toxicity profile is actually very good. It sometimes raises your cholesterol level, and that's not an urgent kind of problem as long as it's not there for too long. It can sometimes cause a rare lung infection, so it's important that this be done in conjunction with your doctor. Actually, the thing the kids hate the most is that about 5 or 10% of them get a mouth sore, like a canker sore, that is uncomfortable but goes away after a couple of days. So that's actually the major toxicity, is a canker sore. This was the design of the clinical trial. So basically, the patients that have progressive refractory, that means they've already been treated with other chemotherapy and it's not working. We treated them with this drug called Everolimus, or RAD001, and then if the tumor either stops growing or shrinks, it's working, and if it keeps growing, then clearly it isn't working. And so the goal of the protocol was to see if it worked, but we also, and this is where families become critically important, was to help us understand the biology of what makes these tumors tick. And so we asked many families, would they be willing not to allow us to do another operation to get a piece of their child's tumor. We said, can we collect a little bit of extra blood so we can see what's happening to the drug and all of the pathways in your blood as we treat you so we can understand what's working. It allows us to understand the toxicity, and it allows us to understand how well the drug is absorbed. Obviously, if you give 2 identical drugs to 2 different people, they may absorb different amounts of it, which obviously would therefore affect how well it works. So in this clinical trial, all of the kids had to have a low-grade glioma. They all had to have received prior therapy. They all had to have radiographically growing disease, and they couldn't have those 2 genetic diseases because, as I already showed you, we already had other treatments for those 2 genetic diseases. So we treated 23 kids across the United States that ranged in age from 3 to 17 years old. They were all otherwise healthy, other than their low-grade glioma, which is expected for kids with this disease. And again, all of them had had prior chemotherapy. In fact, most of the kids had had at least 3 regimens of chemotherapy, like vincristine carbo, TPCV, vinblastine, Avastin, etc., etc. These are not newly diagnosed kids. Some of the kids had also previously had radiation, and their tumors had started to grow again. And fortunately, we discovered that the therapy was very well tolerated. Many of the families did agree to allowing us to do the correlative biology, which means we really had an opportunity to learn from some, but not all of the kids, how the drug was working. And the kids only had 5 major toxicities, and only 2 of them were even really related to the drug. One child had some fatigue, and one had thrombosis. So not major problems for kids that seem to tolerate the drug well. But obviously, you're kind of sitting there as parents. What did you think happened? And obviously, 4 kids had shrinkage. That's good. In 13 other kids, it stopped their tumors that were actively growing from growing. And in 6 kids, it didn't work. And again, the question is, why did it work in 17 and not in 6? It means we still have a lot to learn. And this is called the Kaplan-Meier curve that kind of shows you that after a year, 73% of the kids that had growing tumor still have no growing tumor or shrinkage. And these are what some of the shrinkages look like. So a child with a large enhancing mass lesion of the brainstem gets both smaller and less enhancing. Another child, an infant, with a large diencephalic tumor that again has had dramatic shrinkage, and you can see the middle of the tumor is all turned black because it's starting to necrose and die. And here's another patient again with a large enhancing tumor that is dramatically shrunk and almost it's now just a hollow cavity. So again, we see some really nice results in these patients. The other thing that we learned from the biology is, whereas not surprisingly, in patients pre-therapy didn't have any drug on board, they're pre-therapy so they wouldn't, by the time we started treating them, even just before their next dose, you can see that they're maintaining levels above the red bar the bar that suggests that that's the level you need to turn off the pathway that we were trying to turn off. So we seem to be getting the drug where we want it to be and hitting the pathway that we seem to want to be hitting. And as I said, this is a drug that basically, remember, we're targeting the mTOR, even though most of the mutations are up here. And the question was, is it actually hitting its target? And so the one we looked at is the major molecule that sends the signal, because that's the one we have to stop. And so we took blood cells from the patients from the families that agreed. So it was just a 1 tube of blood, and we took it either before therapy. And what you see here is the black line is the total amount of this molecule, and the gray line is how active the signal is. And you can see that at the beginning, the tumor is sending almost all of the drug, all of the molecule is sending the signal. But by the end of therapy, in fact, within 14 days of starting the drug, the amount of signal being sent is dramatically reduced, and that's exactly what we want, and accounts for the fact that we were able to stop the growth and or shrink the majority of those tumors. So in a kind of very brief summary, this one drug, this once-a-day oral pill, basically had significant activity in the majority, but not all of the kids. It was well tolerated, and the blood levels suggest that it was doing exactly what we wanted it to do. So it's because of that that we now talk about the concept of this being a RAS-RAF disease, because most of the abnormalities occur there. But the one question was that in the meantime, there has now been the development of these MEK inhibitors. And so the question was, instead of doing something all the way down here, where there's a chance for some of the signal to seep away, and maybe that accounts for why not everybody responded, we're now starting a trial with an inhibitor a little bit further up, and this is called the MEK162 trial, and this is now just about to begin. And the reason we're doing this trial, because there are other MEK trials also now starting, is because of the work of a woman named Natalie Agar here at Brigham and Women's Hospital as part of the low-grade glioma, funded through part of the low-grade glioma program, in which she has developed a method that tells us exactly what drugs penetrate the brain and which ones don't, in a very complicated technique that we're not going to go into. Basically, she can take any drug. This is one of the drugs that's being tested, and she can determine their molecular characteristics, and then she can inject it into an animal and then determine how much of the tumor enters the brain. So the dotted line here is the brain tissue, and what you see here is the red is basically blood, and that you can see there, and the green is the molecule that's penetrating into the brain. And obviously, if all of the green and the red line up, then you'll get a yellow color where the two are overlaid with each other, which you see here. But instead what you see is the drug is penetrating throughout the brain. And so we now only do clinical trials for kids with brain tumors on drugs that we know can actually penetrate and have a chance of actually reaching the tumor. Many of the trials that failed before wasn't because it wasn't a good drug, it's because it was a drug that didn't penetrate the brain. And as I said, this will actually be opening next month around the country specifically to test this finding. And I should point out that this is being funded in large part through the Kids Brain Tumor Cure Foundation and other foundations, including the Hoffman Foundation in Nebraska. So the pediatric low-grade gliomas, as we've said, it's a RAS-RAF disease. We've gone over that part. But one of the questions is, what about actual RAF inhibitors, which means hitting it right at the point of the abnormality? Well, this is where that question previously came up about the V600E mutation. So remember, we talked about before where the inhibitory domain is lost in the most common form of this abnormality in the trials that we just talked about. But it turns out that there's another type of mutation that occurs where the inhibitory domain is not lost. In fact, what you get is just a single amino acid mutation that accidentally makes this BRAF molecule that has only this one change now look like it's in its active form, which means it starts to send the signal all on its own. So again, just like before, we developed a molecular test that can identify these patients so that they could then be used for the clinical trial. And this is the test that's currently being used for the international clinical trial that we're running both in Europe and North America. And as we kind of go back and look at, okay, you've been all sitting there listening to this in the context of where is my child's tumor? Well, if your child's tumor was based on the original characteristics of what is a pilocytic astrocytoma, a ganglioma, a low-grade, a diffuse astrocytoma, or PXA, you can see that for many of the patients, for example, with pilocytics, the majority of them have the truncated fusion, the duplication fusion of BRAF, 91%. Rarely do they have the point mutation. Whereas as we start to go to some of the other subtypes, you can see that the number changes. But in no group can you can't just take a pilocytic astrocytoma and say it's probably a truncated fusion and therefore treat it. You have to know which one it is, and the reason you have to know what it is for the following reason that I'll show you in a moment.
Hey, Mark, if you could just go back to the prior slide just for a second. So first off, this is incredible information. I want to just reiterate, because we're getting questions through the control panel here. This will be available. I mentioned it earlier, but just to be clear, this will be available and be recorded. So you can listen to it and then go back to it. We'll, even as soon as tomorrow, be sending you an email with the link to the presentation. So have no fear, you will have access to this on a going forward basis. And we may run just slightly longer than the 2 p.m., a few extra minutes, because there's a lot of questions and there's a lot of important material to cover. Mark, just related to this, if I could again, as I try to understand as a layperson, I think this is an important point. So there were individual questions about RAD-001 and the MEC trial. We will address those because people have been providing them. You've been gracious enough to say that you will follow up with a written response, just like the last seminar, and that will be available to folks. So we will get those individual questions. But I think there's some important points overall for someone like myself who would be a little bewildered by how many different trials and pathways. I think the points that I take from this and talking with you both on this webinar and otherwise is that as a parent, it's important to know the type of tumor you have, and based on that and what pathway that tumor is actually associated with will direct you and your doctor to the right treatment for them. And depending on the pathway that your child's tumor is associated with, RAD-001 might be a great answer, or it may not do anything for that individual child. The important thing is to know the biology and then to match that up against the treatments available. And there's not that many, but at least we have more options today. Is that a way to think about it, to break it down for a parent?
Yep, absolutely, in the sense of we talked about, so all of the mutations along the RAS-RAF pathway that we talked about account for about 95% of these tumors. Again, the mTOR inhibition is at the very bottom, which means there's lots of escape hatches for a tumor to avoid that inhibition before it gets there. So the closer to the abnormality you can get, the better. But at least you can already see that for all of these tumor types, whether they have the V600E mutation or the duplicated truncated fusion, BRAF, the mTOR inhibitor, is already a reasonable option for many. Why it works in some but not all, we still don't understand. We still have more research to do there. What we're going to talk about now is obviously for the MEK inhibitor. That now comes a little closer up. That obviously will not work for patients with tubular sclerosis, but we think it should have some good activity for all of the tumors that were above that, which most of them were. Okay. And now what we're going to do is get into a specific BRAF inhibitor, so even closer to the point of abnormality, and see if we can inhibit those. And that's an international clinical trial we're running throughout North America and Europe with this drug here called dabrafenib, which is just for the V600E mutated BRAF, not for the truncated fusion, the duplicated form that I talked about initially. And this is a child that has here a large enhancing low-grade glioma, received chemotherapy, the tumor progressed afterwards and started growing again. We started treating this child that has the V600E mutation, that point mutation, not the truncated fusion, and within 8 weeks of therapy, it's almost shrunk down to nothing. Again, we're seeing really beautiful responses in the vast majority of the patients that have the V600E mutation and get the V600E inhibitor. So you have to know the mutation in order to do that. And perhaps one of the most important slides that you'll see is this one here, and we're almost done. But this is important because what you see here, for example, is when you have the V600E mutation, remember that I said that BRAF signals MEK, which signals ERK, which goes down that chain to tell the cell to divide. And what you've got here is when you've got this mutation, and you should be looking at this column right here. You basically have a signal here that tells you that phospho-MEK, the signal is being sent, which means it's being sent. It's going all the way down the chain. These are the two things you should be looking at. When you treat this patient or this tumor with a V600E inhibitor, and this is one of the ones, it's the Plexicon drug, basically you can see that all the signal going down that chain stops, which means the cell stops dividing, and this is exactly why the patients have had the responses that we've seen. And so you would say, okay, if my child has a BRAF tumor, they should be getting this drug. The problem is that if you look on the other side, these are children whose tumors have the truncated fusion, the much more common one we talked about, and you can see that they have a little bit of signal, enough to make the cell divide, as it signals phospho-MEK and phospho-ERK. That's what these two stand for. The problem is that when you now add in a V600E inhibitor to these patients, instead of making the little bit of signal that's there go away, you actually amplify it up. You make the signal go even stronger, and a stronger signal means you're actually telling the cells to divide faster. And obviously, your job as parents is not to want to see that happen, and our job as oncologists is not to let that happen. Unfortunately, there was a clinical trial where they actually took kids with the truncated fusion and treated them with one of these V600E inhibitors. And again, the FDA was forced to stop the trial early because the kids basically had explosive growth of their tumor, which means a little bit of knowledge is sometimes dangerous, because just because your child has a BRAF tumor, if you do not know what type of BRAF tumor, you may get them in trouble. So these are what are called the Kaplan-Meier curves. Basically, within 3 months, every child had explosive growth where the tumors were growing rapidly. This is about 1.5 times the volume. Remember that volume is to the power cubed, so this is a huge increase in the amount of tumor that made this have to stop. And the number one problem we're seeing right now is many families hear their kids have the BRAF abnormalities cause low-grade gliomas, so their doctor gives them a BRAF inhibitor and stimulates tumor growth, doesn't inhibit it. So if you don't know the exact mutation, you should not be on these drugs. Okay? So that's kind of the summary here, and perhaps the most important lesson. That the phase 1 trial of dabrafenib for patients that have the mutation is excellent in showing phenomenal responses, but for patients that don't have it, it's absolutely contraindicated. Whereas the molecule just below it, MEK, this is the molecule you should be on if your child has the truncated fusion, because you cannot be on this one. This is the treatment that would be appropriate. And that's what we're trying to get people to understand as they start switching away from radiation and chemotherapy to these new biologic drugs. And then the last slide is kind of, as we think about where we're going, obviously we have to get everyone's tumor tested for its target, because it's the focus on the biology that is going to allow us to understand exactly which mutation you are to develop the appropriate therapy. In concert with that is this concept of, if we develop a drug that doesn't penetrate the brain, then it doesn't have much of a chance of working, and we therefore have to be able to understand that directly in order to ensure that your child is put on the right trial under the right circumstances, so that we maximize the chance. And for those patients who have the right mutation but still don't respond, means there must be a second mutation in there that we're currently missing, which means we have to go back and find those in order to get all of the answers for every child. So what I wanted to do was just kind of close off by recognizing all of the funders, the Pediatric Low-Grade Astrocytoma Foundation, now a Kids Brain Tumor Cure Foundation, and all of the other organizations that have taken part in some of what I've showed you, but in particular, patients and families. If patients and families had not allowed us to start doing this work in 2007, we wouldn't know any of the things that we just talked about, which means we wouldn't have had any of these therapies. For the POETIC trial I talked about, these were the organizations of the centers that allowed us to do that. For the Department of Defense NF1 trial that I talked about, these were the participating centers. And then I just wanted to recognize again the low-grade collaborative that we have here at the Dana-Farber, including all of the members of the program, for which you can see there are a very large number. Some of the people through the Brigham and Women through the program whose work I talked about. Again, we work extensively with groups in Montreal, Nottingham, Stefan Pfister in Germany, groups in both Philadelphia and New York. So this has really become an international effort in order to figure out what drives your child's tumor and how to effectively treat it without causing the long-term damage that we've been doing currently with radiation and chemotherapy. And I'll stop there.
Wow, that was excellent, and I think the participants on this call can understand why we're so appreciative of Dr. Kieran devoting his life and his energies to helping our kids. But I also acknowledge that there was a lot of information provided, and I think this page really gets at what you can do as a parent. I do want to acknowledge, Dr. Kieran, that we've gotten a lot of questions about specifically some of the drugs that you mentioned, and were there, what side effects, what adverse reactions, does it really work for every child who has a certain, pathway indicated? And I think that's probably, because of the time constraints, best done through you responding in a written form, and then we'll be able to get that out to the group. A couple of acknowledgments. I'm glad, Dr. Kieran, you've been a great partner with us, and it's been really important to the Kids Brain Tumor Cure, also known as the PLGA Foundation, for us to have a partnership with researchers all over the country and, quite frankly, all over the world. You mentioned Dr. Stefan Pfister and his German team, and in fact, we just invested further in them with some great, exciting stuff around both the genomics, but also a European drug trial. And of course, we have partners around the country that are part of this effort. So we very much appreciate all of them, and I know some of them are on the call here, so wanted to acknowledge that. Rather than go into any individual treatment, can you comment on the role of the foundations? I know there's one instance where we had provided seed funding of about $300,000, and that resulted in a $1.8 million NIH grant. I know at Dana-Farber, our foundation and others have provided you seed funding that allows you to get to the trial phase. While there's some activity here, maybe you could also comment on, are we in the first, second, third inning, or are we farther along? It feels like we've got a ways to go. So maybe address those 2 points, both what investment is needed and how far along are we in terms of helping these kids?
Yeah, no, we're clearly eons ahead of where we were even in 2007 when all of this started. Even with all, we know that radiation and chemotherapy, non-specific toxins that just kind of try to kill anything that's moving in your body, which means all of the normal things that are moving in your body, which is where we get all the side effects of the immunosuppression, the hair loss, the nausea, the vomiting, that kind of stuff. We know that that's not the answer. Clearly, we have a lot to learn. Many of these, we've only recently discovered these pathways. We're just now applying the drugs. Why is it, for example, that not every child responds to an mTOR inhibitor, a MEK inhibitor, or a BRAF inhibitor, in spite of the fact that they have the right mutation where they should react? Tells us that there's something there. We don't know if you take the drug once, is it going to work forever, or will the tumor start to grow after you stop the drug? We have all kinds of things we have to learn, both in terms of still the biology, better drugs, more effective. All drugs have toxicity. There's no such thing as a completely safe drug. And under those circumstances, we always have to be balancing those risks of toxicities. We know many of those, but not all of them, since we've only been treating kids for a couple of years with many of these compounds. And again, if parents get one thing out of this, it is you have got to have a structure, a system that allows your area of expertise, whether it be your local hospital, a referral. You should never be afraid to ask for a second opinion. It is critical that if people in your local site don't have that expertise, they won't mind that you get the expertise from somewhere. As you've seen, to some extent, the field is becoming more complicated as our understanding and our options increase, which means there's an ever greater need to kind of take the onus on yourself to ensure that all of those issues from the biopsy and understanding the molecular biology are moving forward to getting the final answer.
Excellent. So Dr. Kieran, thank you. And if you look at the slide for the viewers, your job is not to become expert on every one of these treatments. I think, and I speak for myself as a parent, I think our job is to understand our children's diagnosis, work with your local medical center and your care team, but very important, research your options, because as Dr. Kieran just noted, the research and what's happening is changing month by month now, which is exciting, but it also means that perhaps not everyone is fully up to speed on what's possible. And it can make a huge difference if you can get a targeted therapy rather than the toxic chemotherapy Mark was talking about, which doesn't discriminate cells. And so really this key is make sure your medical team does understand what's available. And I am a huge proponent of second opinions to ensure that all the options are considered by your care team. So we're gonna be closing the webinar up, and this is going to be recorded. You'll receive an email tomorrow with the link. And again, Dr. Kieran will be replying to your questions on specific issues. I want to thank Dr. Kieran again for taking the time to support the families on this call. We look forward to the progress that you're talking about, and we're really excited to help contribute. For the parents on the phone, your first priority, of course, is to make sure your child gets the best care. I think the other element to this is that we must take action. And we talked earlier about the research doom loop. It's real, and funding by this parent group and by you really makes the difference. And there's been progress, but as Mark just noted, there's so much more to do. It's really important, and I don't know if every family knows this, that you must ensure your fundraising will go to children's low-grade brain tumor research. There's a lot of great causes out there, but they generally will not support, and the money does not get to low-grade brain tumor research, which is really the magic and what's needed in order to advance and to give therapies that are less harmful to our kids. And you can do that a variety of ways, and you are doing it, but please know that A Kid's Brain Tumor Cure is there with you. And please go to our site that's listed on the slide at kidsbraintumorcure.org for resources and more information. We're in this together, and we can really make a difference together. So on behalf of everyone who put the call together in the Kids Brain Tumor Cure Foundation, thank you, Dr. Kieran, and thanks everyone for attending and being part of this great session. Have a great rest of the day.